All right, if you're staring down your anesthesia finals, you know musculoskeletal trauma can be a beast of a topic. So, we're going to cut right through the noise. This explainer is all about building a really clear, systematic ATLS framework. The kind of framework that gives you confidence whether you're in the exam hall or a real-life trauma bay.
You know, to understand the why behind all of this, we have to start with a nightmare. It's February 1976. An orthopedic surgeon, a guy named Dr. James Steiner, has just crashed his small plane into a cornfield. His wife is killed instantly. 3 of his 4 children are critically injured, and he's about to make a horrifying discovery. The trauma system he thought he could rely on, well, it just doesn't exist.
When Dr. Steiner and his kids finally got to a hospital, the nightmare just got worse. The care they received was, in his own words, crude and inadequate. And right there, in that moment of just unimaginable personal tragedy, a global revolution was sparked. He realized the chaos, the lack of a system. That wasn't an exception, it was the rule. And he knew there had to be a better way. That way became ATLS.
So, here's our game plan. We've just talked about why the system was born out of that tragedy. Now we're going to break down what that system actually is. We'll start with the absolute core principle of the primary survey, life before limb. Then we'll get into the details of the secondary survey, focusing on musculoskeletal injuries. We'll cover those time-critical emergencies you just can't afford to miss, talk about initial management, and then wrap it all up by reinforcing why this systematic approach is literally the bedrock of how we do things now.
Okay, this is it. This is probably the single most important principle in all of trauma care, life before limb. It has to be your mantra. I mean, think about it. As an anesthetist, we're wired to manage physiology first. That gruesome, mangled limb is designed to distract you, but it can wait. A compromised airway, or breathing, or circulation, that cannot wait, not for a second.
And the tool that keeps us honest, the tool that enforces this priority, is the XABCDE mnemonic. You have to think of this as your anchor in the complete chaos of a trauma resuscitation. Now, that X is relatively new, but it's at the front for a reason. You have to stop catastrophic, exsanguinating hemorrhage first. Tourniquet, pelvic binder, whatever it takes. Then and only then we're onto our home turf, airway, breathing, and circulation. Once those immediate life threats are under control, we move on to disability and exposure.
And let's be really clear about something. Musculoskeletal trauma isn't just a secondary survey problem. Oh no, it is a primary survey emergency hiding in plain sight under C for circulation. A pelvic fracture? That patient can bleed out into their retroperitoneum and you won't see a drop of it. A single broken femur? That patient can easily lose 1.5 liters of blood into their thigh. We have to stop thinking of these as just broken bones. They are profound circulatory insults.
Okay, so the primary survey is done, the patient is stabilized, and life threats are being managed. Now we can finally breathe and move on to the secondary survey. This is our structured, head-to-toe deep dive, designed to find everything else we might have missed. And for us right now, this is where we really get to the heart of the musculoskeletal assessment.
So one of the very first, most critical questions you have to ask is this fracture open or closed? Because an open fracture, as you see defined here, means that sterile internal environment of the bone is now communicating with the outside world. It's contaminated. And that one fact immediately changes our entire management plan, because the risk of a deep infection, of a devastating osteomyelitis, just went through the roof.
This slide shows it perfectly, right? Closed on the left, open on the right. But here is the absolute money, the exam-critical takeaway. You do not need to see bones sticking out of the skin. Any break in the skin over a fracture, I don't care if it's a tiny little puncture wound, classifies it as an open fracture, and it must be managed as one.
Our examination mantra is super simple. Look, feel, move. You look for any obvious deformity or swelling. You gently feel for tenderness. You carefully assess active movement if possible. But the part that will save you, in exams and in a court of law, is this: meticulous documentation of the neurovascular status. Pulses, sensation, motor function. You have to clearly document it for every single limb, both before and, just as crucially, after any intervention you do.
Now let's zoom in on the cervical spine for a minute, because for us, this is a huge airway issue. When we're looking at a lateral C-spine image, what we're really doing is tracing these key lines, and any disruption in that smooth, continuous curve, any little step off or weird angulation, that's a massive red flag for an unstable spinal injury. And that's critical information, because an unstable C-spine can turn a routine intubation into a catastrophic core-damaging event.
All right, let's shift gears and talk about the true time-critical, limb-threatening emergencies. These are the big ones. The conditions where the clock is literally ticking, and your rapid diagnosis is the only thing standing between the patient keeping their limb or losing it.
And number one on that list has to be compartment syndrome. It's just a terrifying vicious cycle. So an injury causes swelling or bleeding inside one of those tight, unyielding fascial compartments in a limb. This cranks up the internal pressure, which then starts to choke off the blood supply. The resulting ischemia makes the tissue swell even more, which drives the pressure even higher. And this cycle just spins faster and faster and faster until the muscle and the nerve inside that compartment die.
So how do we spot it? We all learn the 6 Ps, but listen to me on this. The single most important, the earliest, and the most reliable sign is pain out of proportion to the injury. If you have a patient with a broken tibia who is just screaming in agony despite a good dose of morphine, you have to suspect compartment syndrome. If you wait for pulselessness, you've waited way too long. The limb is probably already gone.
And let me be absolutely crystal clear about this. There is no medical fix for established compartment syndrome. The only treatment is an emergency surgical fasciotomy. Our job is to recognize it, give analgesia, and get that patient to an operating room immediately. This is an absolute surgical emergency, period.
So we've identified the injuries, we've spotted the emergencies. What do we actually do first, right there in the trauma bay? Let's quickly cover the foundational principles of initial management. For any open fracture, getting antibiotics on board fast is non-negotiable. This table gives you the high-yield basics. For the less severe type 1 and 2 fractures, we're mainly worried about skin bugs like staph, so cefazolin does the trick. But for those really nasty type 3 injuries, farm accidents, heavy crush injuries, the contamination is much, much worse. And that's why we have to broaden our coverage to hit the gram-negatives with something like gentamicin.
And the initial management of the fracture itself is a simple 3-step drill. 1. Realign. You gently pull traction on the limb to get it back into a more anatomical position. This simple act can actually restore a lost pulse. 2. Splint. Immobilize the limb. This reduces pain and stops those sharp bone ends from chewing up more soft tissue. And 3, the step you can never ever forget, reassess. You have to check and document your neurovascular exam again right after that splint goes on.
Okay, let's bring this all home. The one theme that's been running through this entire explainer and really through the whole ATLS course is the incredible power of a systematic approach. I think this quote from the ATLS manual just says it all, doesn't it? A severe open fracture with bones sticking out is incredibly dramatic. It's gruesome. It's designed to pull your attention away from everything else. But the systematic ABCDE approach, it's the discipline that prevents that distraction. It forces you and your entire team to ignore the dramatic but stable limb injury to find the quiet tension pneumothorax or the hidden pelvic hemorrhage that's actually going to kill the patient.
So let's boil it all down. What are the key takeaways for your exam and for your practice? Number 1, life over limb. Always. 2, stick to XABCDE. It will keep you out of trouble, I promise. 3, suspect compartment syndrome with any pain that just seems wrong. 4, always, always, always realign, splint, and then immediately reassess. 5, get pain relief and antibiotics in early. See? This system isn't just a checklist. It's a philosophy that brings order to chaos, and it saves lives.
So I'll just leave you with this one question to think about. When you're faced with all the noise, the pressure, the blood, the dramatic injuries, how will you personally make sure that this structured, systematic ATLS approach remains your anchor, allowing you to bring order to that chaos and deliver the best possible care for your patient?